King George Medical University. I welcome you all to the concluding session of our webinar series in recent advances in pediatrics. I would like to extend my heartfelt gratitude to each one of you for joining us today and throughout our webinar series and making it a success. And as many of us are aware, today we'll be talking about pulmonology, and I feel so honored and privileged to call upon our first speaker to begin with today's proceeding, Professor and Head of the Department of Pediatrics, Dr. Shally Awasthi, who will be talking about allergic bronchopulmonary aspergillosis. I welcome you, ma'am.
Thank you very much. Can you see my screen, Arpita?
Yes, ma'am, I can.
Okay, thank you very much, Arpita, and all of you. Today, I would be talking about allergic bronchopulmonary aspergillosis. The reason for my picking up this topic is that what the mind doesn't know, the eyes don't see. And as I go through the lecture, you will see what I am talking about. So this is a condition which is uncommon yet important, and we should know about it. So today, when I will be speaking, the learning objectives will be to understand the etiology of ABPA, to know the clinical and imaging modalities used to diagnose it, and also describe the management and certain take-home messages and the way forward. I have a linker case, a patient admitted in our department, in our Monday team, and I would be referring to this linker case 2 to 3 times during my discussion. And then I have a small case report, which I will showcase to you all. So this index summary linker case was a 3-year, 6-month-old female child admitted on 10th of May this year with complaints of fever for a week, difficulty in breathing for a week, was lethargic, and had 3 to 4 episodes of foul-smelling stools prior to admission, 3 days. And as expected, she was tachypneic, had bilateral Krebs and bronchi, grade 3 clubbing, and she had failure to thrive. Now, she was a known case of cystic fibrosis, diagnosed in the neonatal period with a positive sweat chloride test, 2 readings above 60 milliequivalent per liter. She had fat intolerance as evident by Sudan black staining of stool. And in her sequencing, which was done in Sanjay Gandhi PGI, she was heterozygous for Delta 508. So she was diagnosed in the neonatal period as she had meconium ileus and was operated on day 2 of life. And she had history of 3 previous admissions. Now, as I show you these 3 admissions, first admission was, of course, in the neonatal period, thereafter 7 months, 11 months, and you see there is a big loss to follow up, whereafter she came at 3 years, 3 months, and then at 3 years, 6 months. When she was admitted, we gave her oxygen, nebulization, antibiotics, chest physiotherapy. However, during the hospital stay, there was worsening of distress with increasing oxygen requirement, and from non-invasive, we had to shift to invasive ventilation. There was massive terminal hemoptysis. Here I show you her investigations. Hemoglobin was low, total counts were high. Absolute eosinophil count was 732. This is her X-ray on admission. See the X-ray very carefully. You can see the cardiac shadow. You can see paracardiac shadows, which I will tell you what they are, but see them and remember them. And then her HRCT was done at the age of 11 months to be precise, which is showing what you see here. Remember these images. Outcome, this girl expired. Total hospital stay was 5 days. She was a known case of cystic fibrosis with acute exacerbation, with respiratory failure, with exocrine pancreatic insufficiency. Double query, did she have ABPA? Or was she too young? Was it in the interim follow-up period of 2 years, or between the visit at 3 years, 3 months and 3 years, 6 months, something happened? We will see that. Now, If you say she is too young, the youngest case report from India done by, published in 2017, the reference is given here, was of a 4-year-old female diagnosed with ABPA on the basis of history of bronchial asthma. She was positive for Aspergillus fumigatus on skin prick test. Her total serum IgE levels were high. Her chest X-ray was positive, and her HR thorax was, CT thorax was positive. And I would not be showing you the details of that because we will be discussing further. Now, from here, we go to the introduction. My lecture chalega pura. So in introduction, ABPA is, as we know, a fungal infection of the lung. It occurs due to hypersensitivity reaction to antigens of Aspergillus fumigatus after it has colonized the airway. It predominantly affects patients with bronchial asthma and cystic fibrosis, the two cases I showed you all, and it characteristically presents with bronchospasm clinically, pulmonary infiltrates on X-ray or CT, eosinophilia on peripheral blood count, and immunological evidence of allergy to antigen of Aspergillus species. Now, an infection by Aspergillus species causes a broad spectrum of illness in humans and depends on the immune status of the host, ranging from a hypersensitivity reaction at one spectrum to another spectrum of direct angioinvasion. And today I will discuss a case, and the last speaker, Dr. Akansha, will also discuss a case, the entire spectrum. Vulnerable population are patients with asthma, cystic fibrosis, and those who are allergic to Aspergillus. There is a genetic susceptibility. Those patients who are HLA DR2, DR5, possibly DR4 or 7 have increased susceptibility, and those with HLA DQ2 perhaps contributes resistance, and a combination of these may determine the outcome of ABPA in cystic fibrosis and asthma. Now, there are more than 100 species of Aspergillus, but those causing disease are basically fumigatus, niger, flavus, and clevatus. Now, I told you on one spectrum, there will be sensitivity, then there would be ABPA, and on the other side, there would be invasive, angioinvasive. So studies have reported that Aspergillus sensitivity can be present in 25% of asthmatics and as much as 50% of cystic fibrosis patients. In a study published from All India Institute of Medical Sciences in 2017, Dr. Lodha et al. Found that approximately 11% of severe asthmatics were having Aspergillus sensitivity, and 3 times or 4 times the number sensitivity was there, and in about 11 to 12%, and fewer of them had ABPA. Now, ABPA in asthmatics could be approximately 13% and in 9% in cystic fibrosis. However, if you take the entire burden of disease worldwide, 4 million people are affected. Highest incidence occurs in winter season around the world, and it is attributed to secondary to fallen leaves, which when they sort of decay, you have Aspergillus on them. So what are the risk factors for ABPA in cystic fibrosis patients? As I told you, sensitivity 3 times more than the ABPA. And the identified risk factor of ABPA in cystic fibrosis are, we should remember, long-term use of azithromycin, Aspergillus colonization, which increases the risk, bronchial colonization with a gram-negative bacteria, which is multi-drug resistant, which is Stenotrophomonas, which increases the risk of Aspergillus ABPA, cumulative dose of inhaled steroids, longer duration of Pseudomonas colonization, and from India, publications have said that those who are greater than 12 years, those who have a high cystic fibrosis radiological score, and where there is presence of atopy and eosinophilia are at increased risk. So what is the pathophysiology? First of all, it is incompletely understood. When there is exposure of atopic individuals to fungal spores or mycelial fragment, they result in formation of IgE and IgG antibodies. T helper cells play an essential role in hypersensitivity reaction caused by AF antigen by releasing pro-inflammatory cytokines such as IL-8, which causes epithelial damage and disruption of protective barriers in the lung. There is also release of IL-4, IL-5, IL-13, which increase the blood supply, which increase airway eosinophils as well as IgE. Now here's a small diagram we have made. Immunocompetent individuals, when they inhale AF conidia is the spores, they eliminate them. They have innate immune mechanisms and there is no manifestation of pulmonary fungal infection. However, when an immune compromised person or a person with imbalanced immunity inhales these conidia, they cannot eliminate conidia of AF. AF means Aspergillus fumigatus. And there is chronic allergic inflammatory response, tissue injury in the lung leading to ABPA. Now here is a diagram I have taken. The source is given here. This arrow shows you the contact, and here is the time. So the AF is inhaled, conidia are inhaled. They adhere to the lung. They are internalized. After internalization, there is swelling of the cells of the lung, immune response, and even though there is an immune response, there is germination within the lungs, and there is growth of hyphae within the lung of immune incompetent people or those who are allergic or those who are at risk of ABPA. So what happens when this happens? There is chronic bronchial inflammation. There's eosinophilia leading to areas of parenchymal scarring, remodeling of airways, and ultimate bronchiectasis. Now, if you do a bronchoscopy or if you do a radiological investigation, you will see impacted mucus plugs, and on histopathology, there will be fungal hyphae, fibrin, Charcot-Leyden crystal, Cushman spirals will all be there when you do a histopath. So when do you suspect ABPA? History of recurrent episode of wheezing and radiological evidence of patchy, fleeting pulmonary infiltrate and bronchiectasis, or history of uncontrolled asthma with increased frequency and severity despite optimal asthma medication, despite adherence to treatment, or there is history of cystic fibrosis. So clinical presentation is nothing unusual. We know it: cough, dyspnea, chest pain. If they expectorate blood-stained sputum or sputum with brown mucus plugs, and non-specific complaints like anorexia, fatigue, generalized aches and pains, low-grade fever, weight loss, and remember, fungal sinusitis with purulent nasal discharge can also be present in these patients. Physical examination will mirror whatever we see in asthmatics, whatever we see in cystic fibrosis, like wheezing and rhonchi, like crepitations, like tachypnea, like fever, like other features secondary to lung infection in both these category of patients at high risk for cystic fibrosis. So how do we evaluate them? We have to do an Aspergillus skin test in those whom we suspect ABPA. To diagnose sensitization to AF, AF is Aspergillus fumigatus. It reveals immediate cutaneous sensitivity, and it is a type 1 hypersensitivity reaction, and it indicates there is presence of AF-specific IgE antibody. Now, we do it by Shiv-Puri criteria. On the other arm, we put a control with histamine, and within 20 minutes, we take the reading, comparing the induration on the site where we have put intradermal AF antigen, and we get recombinant panel of antigens, not only AF, but Conidia and others, depending on the panel we have ordered. Now, the intradermal skin tests are more sensitive than skin prick test for diagnosis of Aspergillus sensitization. So, blood abnormalities, elevated serum IgE over 1000 IU per ml. However, pediatric levels are being worked up, and each country, each site should have their specific levels. Elevated specific serum IgE to AF, presence of serum precipitin by gel diffusion or raised specific IgG to AF, and peripheral eosinophilia, which can be often absent, especially if the patient is on oral or inhaled steroids. Now, radiologically, I told you we get pictures which are suggestive. However, chest X-ray has only 50% sensitivity for diagnosing ABPA. It shows parenchymal infiltrates, bronchiectasis, mostly in the upper lobe. However, all lobes may get involved. It could be fleeting. HRCT is the investigation of choice to detect bronchiectatic distribution and abnormalities that are not detected on chest X-ray, such as centrilobular nodule and tree in bud appearance. So we can have patients on ABPA with no abnormality on chest X-ray or an HRCT. Therefore, only 50% sensitivity of radiological abnormality, and it is called ABPA-S, that is only serologic. Or we have ABPA with central bronchiectasis known as ABPA-CB, central bronchiectasis. Now, these are some interesting images we are showing you. This is the finger and glove opacity here, finger and glove opacity, suggestive of mucoid impactation in dilated bronchi. This is my index case, which I showed you first. See this image, see this image. Don't you see? These are finger and glove appearance. Then there could be tram-line shadows, suggestive of parallel linear shadows extending from the hilum in the bronchial distribution, reflecting longitudinal views of inflamed edematous bronchi. This finger and glove sometimes is like toothpaste shadow, representing mucoid impactation of bronchi. And you get ring shadow reflecting dilated bronchi with inflamed bronchial walls. Here you are seeing a signet ring shadow. There are other shadows in HRCT, I'll show you. This is a radiographic examination. A showing you left upper lobe collapse. The arrow is showing it's collapsed. And after treatment with glucocorticoid clearing. So there will be stages. This would be a stage of active disease. This would be a stage of remission, as I'll tell you later on. Here are three HRCTs, A, B, C. In A, what you are seeing, the thin arrow is showing you cylindrical bronchiectatic cavity, and you are seeing a signet ring appearance on this thick ring, arrow. The B is showing you varicose bronchiectasis, and the C is showing cystic bronchiectasis. This is a HRCT showing classical central bronchiectasis with sparing of peripheries, and here is my index case. The index case also had central bronchiectasis. Here, peripheries are spared, but more in the center. So that was my index case, which we are following up throughout. So therefore, there is a revised radiological classification of ABPA based on HRCT. I told you serological ABPA, which fulfills the diagnostic criteria, which I will tell you later on, in absence of radiological findings. Then we have a ABPA-B bronchiectasis, which satisfies criteria of bronchiectasis. We have ABPA-HEM, high attenuation mucus, ABPA, CPF, chronic pulmonary, pleuropulmonary fibrosis. So what test will we do? We will do a pulmonary function test, which will initially be obstructive and then go on to restrictive findings. Bronchoscopy, which will show mucoid impaction. And I showed you that bronchial brushings may show eosinophils, fungal hyphae, and eosinophil filled Charcot lesion crystals and hyphae filled mucus plugs, pathognomonic of HPPA. I have written for those of you the hyphae branch at 45 degrees in Aspergillosis as compared to 90-degree in mucormycosis, which we saw just now. And bowel fluid will show moderate eosinophilia, especially in steroid naive patients, increased levels of IgE, IgA, but not IgG against Aspergillus. And sputum culture is not diagnostic. It can be positive. It will reveal a diagnostic organism. We can do a drug susceptibility testing. So how will you make a diagnosis? And 3 minor. The 8 major criteria are written here: asthma, fleeting shadows, cutaneous reactivity, elevated IgE, precipitating antibodies, eosinophilia, elevated IgE-Ng, and bronchiectasis, and 3 minor. Now here the problem with Rosenberg-Patterson is that if the patient is, we don't know how many major and how many minor should be taken. Each group takes its own, sometimes 6 major, sometimes 2 minor. There is no consensus. And then also there's no consensus whether the patient is in remission or in relapse. So there was a criteria, revised criteria proposed by ISHAM group, that is International Study Group on Human and Animal Mycosis in 2013. They had 2 predisposing criteria: bronchial asthma, cystic fibrosis. Obligatory criteria, both should be present: type 1 Aspergillus skin test or elevated IgE, total IgE greater than 1000 IU, and 2 of the 3 criteria, that is presence of precipitating or IgG antibodies, radiographic pulmonary opacities, and total eosinophil count greater than 500. In patients who meet all other criteria, an IgE less than 1000 may be acceptable. I take you to my linker case. Predisposing condition present, cystic fibrosis. Obligatory criteria could not be done. Whatever, I told you what the mind knows, I see and we do. And of the other criteria, they said 2 out of 3 positive. Yes, 2 were positive. Radiological opacities were consistent and IgE count was elevated. When did she develop ABPA? We don't know. Again, there are criteria for ABPA in cystic fibrosis, deteriorating cough, similar criteria. Similar criteria, again our index case had 1 and 4 positive and 2 and 3 were not done. Big question, ABPA, I've put her X-ray film here again as a learning for all of us who are dealing with patients. Now there is in asthmatic patients a staging criteria, which has made therefore the initial 1974 criteria perhaps defunct. Stage 4 is asymptomatic, no previous diagnosis of ABPA, but the patient is she has fulfilled the ISHAM working group criteria and she's controlled or he's controlled. Stage 1 is acute stage, no previous ABPA, uncontrolled asthma, meets the diagnostic criteria, could be with mucus impaction, without mucus impaction. 2 is response, clinical radiological improvement, decline in IgE greater than or equal to 25% of baseline at 8 weeks. Stage 3 exacerbation, worsening, clinical or radiological, increase in IgE greater than 50% from baseline, established during response and remission. 4 is again remission, sustained improvement, IgE below the baseline for greater than 6 months of treatment. Stage 4 becomes treatment-dependent ABPA, and 4B becomes glucocorticoid dependent. I am not reading through the details. They are visible to you. And then the stage 6 is advanced BPP with bronchiectasis, and they go into chronic type 2 respiratory failure. So with this, now what we have known what is Aspergillosis, how does fumigatus enter into our body, who are the patients at risk, what do we see in their radiology, what do we see in their investigation, why 1974 criteria were replaced by the 2013 criteria. Now it is time we know something about treatment and management. The goals are we control symptoms, we prevent exacerbations, we preserve normal lung function. How do we do that? We also opt for non-pharmacological treatment. We enhance airway clearance by nebulization with hypertonic saline with salbutamol and mucus clearance valves or percussion vent. We avoid areas and environmental conditions with high mold count, such as decomposing organic material or moldy indoor environments, etc. So what are the pharmacological treatment? The first thing is controlling symptoms. How do we control symptoms? We control symptoms by giving anti-inflammatory, which are steroids. We have, for controlling symptoms, sometimes we require antifungals. Very occasionally, we require IgE therapy, anti-IgE therapy. And for controlling symptoms, we will require antibiotics as and when required. For prevention of exacerbation, we will do the environmental control, what I told you earlier. So for our prevention of symptoms, we give steroids. Systemic steroids are the primary line of therapy to relieve symptoms and decrease airflow obstruction. They decrease serum IgE, reduce peripheral blood count, and resolve pulmonary inflammation and infiltrates, and prevent irreversible lung damage. We use drug of choice is prednisolone. Dose is 0.5 to 1 milligram per kg for 2 weeks, followed by 0.5 milligram per kg alternate day for 6 to 8 weeks. A subsequent taper by 5 to 10 milligram every 2 weeks over 3 to 5 months. The duration of treatment depends on the activity and severity of the disease, and a low maintenance may be required for long-term control of symptoms and for prevention of recurrence. So the drug of choice is steroids. This index case, at the age of 3 years, 3 months, did she require steroids? She was lost to follow-up. We did not give her steroids. She was not in our follow-up, actually. Now, when we follow up these patients, we have to do IgE levels every few months of acute episode to look for exacerbation. And I told you that when we are following this patient, every 2 months, we should follow these patients and get an IgE done. If IgE level rises more than 100%, we escalate steroid therapy. And we may want to add inhaled steroids to control bronchospasm, and it may minimize the dose of oral steroids. Now, stage-wise follow-up is required. I told you stage 1 and stage 3. 1 is asymptomatic, 3 is in remission. They may require oral or IV steroids depending on the level of symptom. Stage 2 is the patient is in 1 and 3. 1 is Asymptomatic, 3 is relapse, 2 is remission. They require regular follow-up. Stage 4 requires long-term steroids to control symptoms and to keep IgE level at baseline. It should not exceed above, at least it should not be more than 50% of what is the baseline of that patient. And 5 and 6 require long-term steroid use. The second drug which we are using, which is used is antifungal, which decreases the fungal load, that reduces inflammatory activity, and it acts as a steroid sparing agent. The drug of choice is itraconazole. The dose in children I have written is 3 to 10. Average we give at 5 milligram per kg per day in 2 divided doses for 16 weeks. And it leads to significant reduction in steroid dosage. It decreases IgE level, resolves pulmonary infiltrates, improves exercise tolerance, and improves pulmonary function test in these patients. When do we give it? We give it in patients who are steroid dependent. So we will not give it in the first stage. We will give it when the patient is steroid dependent or the patient is having frequent relapses, and we will give it where the benefit of treatment with itraconazole outweighs the risk of treatment. The other antifungals have been used in ABPA, but they are ineffective. These are nystatin, amphotericin B, this one, other one is miconazole, clotrimazole, and natamycin. These drugs are ineffective in controlling ABPA. And the newer antifungals which are of some benefit are voriconazole and posaconazole. Both the drugs have clinical improvement with reduction in requirement of oral steroids, improvement in asthma control. And in this table, I'm showing you that the doses. Here is the dose of voriconazole. First, there is a loading dose of 6 milligram per kg 12 hourly for the first 24 hours. Maintenance IV dose 4 milligram per kg 12 hourly. And then an oral maintenance dose of 200 milligram twice a day. Same for posaconazole. Posaconazole is given as an oral suspension. Per kilogram dose is not there. Oral 200 milligram thrice a day. And then we have an intravenous also. Depends on what you want to do and what drug you want to use. Now, posaconazole is given after meals. Voriconazole is given empty stomach because posaconazole binds with lipids in the meal and absorption is better. Voriconazole absorption is impaired after a meal. Merit is high efficacy. Second line therapy in some cases, the cost is high. Certain trials have been done with nebulized lipid amphotericin B. However, efficacy of nebulized lipid amphotericin B is still not determined. Hence, it is not of use in treatment of ABPA. I'm sorry for the spelling mistake. And then, of course, there are antibiotics which are used depending on what infection is there and what we are suspecting and what the culture sensitivity is showing us. Now, what about monoclonal antibodies? They prevent binding of IgE to the Fc epsilon receptors of mast cells and basophils. We know that omalizumab is there. 375 milligrams subcutaneous injection every 2 weeks for 4 to 6 weeks. The dosage depends on total serum IgE level, largely in cases of uncontrolled asthma in older children. In ABPA, despite high levels of IgE, routine dose of omalizumab is sufficient. Now, here is a table I've shown you all. Here is the weight of the body weight in kilogram. So obviously below 20 kilogram, there is no recommendation. Here is the baseline IgE level. I told you it was 375 milligrams subcutaneous. So 375 milligrams subcutaneous somewhere is between the Ig levels of more than 1000. Even if the Ig levels are very high, 375 milligram is what is being recommended. Administration every 2 weeks. And here also every administration every 2 weeks for at least 4 to 6 weeks. This is the table and a reference chart for weight. And this is where we give IgE in patients of ABPA if required at all. So now we know how to identify in at-risk patients, how to treat. And after treating, before we start treatment, we have to have differential diagnosis of undiagnosed lung infiltrates, persistent recurrent pneumonia, and bronchiectasis. And my senior resident and now my colleague will talk to you about persistent pneumonia in the last talk today. So our differential diagnoses are, we have to differentiate between a simple corticosteroid dependent asthma without ABPA, severe asthma with fungal sensitivity, cystic fibrosis without ABPA, bronchiectasis unrelated to ABPA, chronic necrotizing aspergillosis which requires a different treatment, chronic eosinophil pneumonia, Chrook-Strauss syndrome, bronchocentric granulomatosis, acute eosinophilic pneumonia, most important pulmonary TB, and hypersensitivity pneumonitis. I will not go into details of this because my focus is on ABPA. These other entities we should remember, they, except for pulmonary TB, except for steroid dependent ABPA, other conditions are not so common. So what is the prognosis? Is it that if the patient has ABPA with CF or BA, is she gone or is he gone? Natural history, progression, remission, recurrences are not well understood. Patients without central bronchiectasis at the time of diagnosis tend to maintain lung function better despite occasional exacerbation. Go back to our index case. Our index case had central bronchiectasis at the age of 1 year. So without appropriate treatment, with appropriate treatment, long-term control of ABPA is feasible. Durable remissions are common. So even though our index case had central bronchiectasis at the age of 1 year, had we diagnosed her, if she had ABPA, perhaps we should have kept her in a longer duration of remission. So these children, despite treatment, develop recurrent asthma exacerbations and steroid dependence. They develop aspergilloma. Again, the last speaker will show you aspergilloma case. They develop invasive aspergillosis, chronic pulmonary aspergillosis, cavitation, localized emphysema, chronic recurrent lobar atelectasis, honeycomb fibrosis, and complications related to bronchiectasis, hemoptysis, recurrent pulmonary infection. Again, our index case had as a result of bronchiectasis, terminal hemoptysis. So ultimately, patients need to be educated. We as pediatricians need to be educated that yes, there is a condition like ABPA. It can occur at young ages. Youngest case reported is 4 years from India, but perhaps even younger. If we are on lookout, maybe. If there is worsening of symptoms on treatment or new symptoms develop in a patient of BA or CF, consult a pediatrician who takes interest in pulmonology. If there is secondary infection in ABPA with central bronchiectasis, they have a higher chance of secondary infection and complication. And if fever of hemoptysis occur, that's a bad danger sign. You might lose that patient. So in these patients, remember ABPA and investigate. Now, skin testing is not very commonly available, even in our center. And we are requesting our colleagues to start skin testing, to do precipitin test, to do Aspergillus specific antibody test, because now we have a mycology lab and a center of excellence in our institution. So what are the pearls? I have exceeded by 2 minutes, Arpita. few pearls. All patients with asthma and cystic fibrosis, regardless of severity or level of control, should have routine screening for ABPA using AF specific IgE levels. Remember that, because we are treating, all are treating asthma, some are treating CF. Glucocorticoids should be the first line of therapy. Itraconazole reserved for those with exacerbations and glucocorticoid dependent disease. Skin prick test or measurement of specific IgE is a reasonable first step in patients being evaluated for ABPA. And inability to establish IgE sensitization to Aspergillosis virtually excludes ABPA from consideration. And if skin prick testing and or IgE patient is positive, then do a total serum IgE, precipitant to Aspergillus and a eosinophil count. Chest imaging and HRCT should be done. And remember, the last is most important. Early detection, early treatment can prevent development of bronchiectasis or pulmonary fibrosis that otherwise occurs in later stage of the disease. You can give our children better quality of life, longer quality of life. So with these words, thank you very much for your kind attention. And I finished in 43 minutes, Arpita. Thank you all.
Yes. Thank you so much, ma'am, for such an excellent and lucid talk. It has indeed expanded our knowledge and made us aware that we should have a high index of suspicion for ABPA while treating patients with cystic fibrosis and uncontrolled asthma. So thank you so much, ma'am, for it. Any queries from the audience? Ma'am will be so happy to answer them. So we move forward. Okay, there's a query, ma'am. In a child with newly diagnosed asthma, when should we start screening by IgE levels? Only on clinical worsening or routinely?
Nishant, you had the privilege of working in a center which has started DM in pediatric pulmonology. However, I would like to say that in a newly diagnosed asthma, we would not begin as a first line test by screening for ABPA or even looking for sensitization to AS. I told you 3 times higher number will have sensitization to AS. So when should we start? Yes, we should start when it is a difficult to control asthma or when there is clinical worsening. It should not be done routinely. But if the patient is if we are using steroids for management of these patients, so we are going up in GINA guidelines and management. In that patient, yes, every 6 months we can do AS screening if the facility says, because there is a data published that in patients with severe asthma, a significant proportion, preventable proportion were AS sensitive and some of them were having ABPA. I hope I've answered your question, Dr. Nishant. The second question is... Second... Okay.
No, ma'am, that's just...
There's nothing on hats off. Keep your hats on, Siddharth. Thanks.
Thank you so much, ma'am.